For our next session, it's my immense pleasure to introduce the distinguished speaker, Dr. Rakesh Dhurkure. Sir is the Director of Department of Surgery, Maringo Asia Hospital, Gurgaon. He is highly respected in the field of laparoscopic surgery and known for his pioneering work in management of pelvic floor disorders and his innovative approaches in minimal invasive surgery. Today, sir is going to talk about from silence to suspension, laparoscopy suspension surgery for SUI, prolapse and pelvic descent. Over to you, sir.
Thank you.
Welcome, sir.
So, first of all, thank you to the walls and the organizer, the chief, sir, Dr. Mishra, sir, Bhalla, sir, and everyone in this group. And good afternoon to my seniors, colleagues, and to the juniors. I am a general surgeon, laparoscopic surgeon, but I am a technical gynecologist as well. So I do the gynecological surgeries because there is no nukes in the corner in the body which is where a scope cannot reach. So if my telescope can reach, then I will go to that organs as well. Sorry, I'm intruding into the field of the gynecologist, but it's a win-win situation for both of us because the surgery involves the pulling up of the bladder, which is a urologist field, the vault, which is a gynecologist field, and the rectum as well, which is a general surgeon's field. So I've chose this topic of silence to suspension because at times in my OPD, when I'm free days, when I see an old lady sitting, talking to me for any kind of the abdominal pain or something, if I just ask a simple question, how many times do you get up in the night? Then she feels shy. She doesn't like to open up in front of their family members. Then, she opens up to me and talks a lot about her urinary complaints and symptoms. And the old ladies, very much, because I feel very much connected to them because, there is no much people who can wipe out their tears. So that's the silence to the suspension. From their silence in the OPD or in their routine life to the suspension that we can offer to them. Statistically, if we see, because of this shyness that there is less of the female doctors who are available into the peripheries, fear of the surgery. Because of the fear of the surgery, they had to undergo the normal delivery as well, and because of the normal delivery, the loosening of the ligaments happen. And lack of money dependency onto the husband. No one listens to them. Actually, they are a little bit neglected. Let's not talk about the high society people, but yes, there are ladies from the lower socioeconomic group, they suffer more. So they accept because this is the usual fate of life, and this will happen because if you have given birth to 2 or 3 children, this is going to happen. So they think that this is normal. They don't go to outdoor environment. They don't go and seek the help of any kind of a doctor. They think this is normal. So causes, we all know the normal delivery, some COPD, wherever there is a strenuous muscular exercises happening onto the tummy, may it be the constipation, coughing, wet lifting, pelvic surgery, any injury to the urethral area, increase in the gravity, increase in the age will increase the chances of prolapse to happen. And any BMI more than 25, this I got it, but I think more than 35 or 40 should be the BMI. So those were the indication of surgery from the medical point, but these are the indication of the surgery from a social point. The embarrassment lady feels wherever they go to any kind of social gathering. If they go, they will first don't look for the stage, they don't look for the center of attraction in that area, they first look for the toilet sign. And they love to sit close to that area because if they feel an urge, they will run to that space, that area. They love to live in the isolation, depression, anxiety. They will refrain from going to outdoor walks. Married life goes down, and the sleep disturbances. These are the major indication that one should counsel them, do a nice clinical examination, and then proceed. anatomically, cervix is our center axis of the pelvic area, where all kinds of the ligaments, they get attached. So this situation is very much common in the post-hysterectomized ladies. More is after hysterectomy, after 1 year, it is 1% chance, but say with the increasing more than 5 years, about 5%, they would require a surgery. Symptoms would be in 35 to 40% of the cases. In the process of the evolution, I will tell you in the next slide that why does the prolapse happen more in the females. This is the story, or this is the case is presented into a canine population, the animals. So when we were walking on the 4 legs, then at that time, in the first picture, if you see, the bladder neck is an abdominal organ. So whenever there is an increased cuff or pressure onto the anterior-abdominal muscles, so the pressure gets transmitted, number 1 onto the bladder, number 2 onto the urethra and the bladder neck. So both the forces, they oppose each other, and it does not happen. The incontinence is taken care because the bladder neck is anterior or superior to the pubic tubercle. But in the second picture, you see the bladder has receded down. So the pressure is getting exerted only onto the urinary bladder. So that's the reason. And if you look at the anatomy of the urinary bladder as well, there is not a great amount of a thick musculature. In the males, there is a prostate, there is a good internal sphincter, and everything is there. But in the females, the internal sphincter is not really a very muscular organ. So coming to the treatment part of the SUIs or the prolapse, there are so many of the things, non-surgical to the surgical. Stage 1 involves some kind of behavioral changes, avoid chocolates, drink less of the water before you go off to the bed, do some exercises, some injections are being done perurethral, like agents around, the filling agents around the urethra on either of the sides. They give some kind of a false pressure and gives a little bit of the kinking or the closure to the urethra. Slings operation, quite much in the fashion, the TVT and the TOT, so vaginal and the obturator tips. Artificial sphincters, not much used. And the last 2 things that I would like to talk is the colposuspensions and the pactopexies. So this is a TOT tip, where they make a small cut into the anterior wall of the vagina, under the urethra, on either of the side. There is a special kind of the needle attached with the marceline tape which comes. So one needle goes into the right side, one to the left side. Usually it avoids any kind of the injury to our blood vessels or to the bladder or to the bowel, and it comes out through both the sides, the obturator, between the superior pubic rami and the inferior pubic rami. We call it the obturator foramens. And then you leave it without much of the tension. Next thing is the TVT, transvaginal. Here more are the chances because you have to go just behind the pubic bone and hitch it up. So it gives a more of a tension to the urethra. This is not a very much favorable or a good thing. Sorry for the next slide, because in the next slide there will be a little bit of the disturbing pictures like this. I think that this is the picture which explains the TOT or the TVT tape. It's something kind of a noose around the neck. If you pull a drowning person with a rope around his neck, I'm not talking about the hanging, saving someone from a drowning. If you pull them up with the rope around the neck, what is it going to do? It is not going to help that person. It will more strangulate further, and it will lead to a scar. If the urethra is not dying, it will leave with a great amount of the scar. The pressure onto the urethra, onto the right side, left side, and onto the ventral side is so much that only the ventral aspect is only saved of the urethra. Rest of it, that's why the chances of the mesh erosion is there, because there is a pressure, and we are the laparoscopic surgeon. Wherever there is a force used, that is the job of orthopedician, not for the surgeons. So I say that our repair should be tension free, loose. That's what has been taught, and we should implement that thing as well into this practice. If you compare the TOT and the TVT tape, one is from the obturator foramen, one behind the pubic bone. The incision is into the vagina in both the cases, and in the inner thigh for the TOT, and in the suprapubic area, as I told you, just behind the pubic bone is in the TVT tape. Neck injury, the bladder neck injury chances are low in the TOT because it goes laterally. TVT is high because it is towards the bladder. Groin pain is high in the TOT one because the incision is there and the mesh is there. Depends on the mesh reaction, body, how the body is going to accept this tape. That also depends a lot. Success rate is good, but the failure rate is equally good. 10% is too much. Mesh erosion rate, 7, 8 to 10%, it happens. I've seen it, the urologist doing it most of the time. I don't do it, the TOT, TVT tape, but yes, there is a lot of dyspareunia later on in the life. So these are the risks: injury to the bladder, urethra, blood vessels. The long-term complications also, recurrence. The mesh gets loosened up or the mesh erosion. Retention of the urine is also very much common. You have to recatheterize the patient once, twice. In the middle of the night, lady will come back that, I need another catheterization. So your casualty officer will keep on troubling you most of the time. This happens in the initially some time. It happens. Even though the moment you remove the catheter, retention happens in some of the patients. But look at this slide. There's the pectopexy or the sacropexy. This is something which is, we call it as a hammock kind of a lifting of the urethra, whole of the urethra. Here we are pulling out a drowning person with a rope around his chest wall, which is not constricting too much. It is life-saving. So you need to give a support and give a life to the urethra as well and preserve the functionality. And in this thing, success rate is also very good, and because the mesh erosion rate, if I tell you that we use a different kind of the mesh, I have not seen the mesh erosion rate. I am doing it for last 6 years, have done along with all the cases with the gynecologist because they are the primary admitting person, and they set up the indication, and then we decide, and technically part, we take care of it. So we have not seen any kind of the mesh erosion till now. Even we do it along with the hysterectomy as well. Along with the TLH also we do it, but we have not seen any kind of the mesh erosion. So this is what is the sacropexy or the cystocele repair. The mesh is used. It is, we try to tie it, make a plane between the bladder and the anterior vaginal wall. We go very much down there and then make up a stitches, pull up the sling from the right side of the pelvis cavity. Left side there is a sigmoid column. So you go to the right side behind the peritoneum, make it as a retroperitoneum. There are ways, and then you bring it to the sacrum and then you fix it to the sacrum. Easiest way is to use the tacker to fix it to the sacrum. But I say there is no future without the suture. Learn the suturing, because this surgery is not possible without any kind of a stitching to the anterovaginal wall. How softly that you take, preserving the, don't go through and through to the anterovaginal wall, and then fix it to the sacrum as well, very diligently with a strong needle. Suture material that one should use should be the polyester suture material, the green color, the pastel green color, because it is the softest of the material and a permanent stitch. And the use of the mesh should be a composite mesh. Like this is the mesh, type of the meshes. One is the macroporous, microporous. Macroporous, the holes are bigger. It is good to be used in such kind of the practices. Microporous, they are thick and the heavy mesh, so chances of erosion is very high because you need a great strength. We don't need to give a great strength to the tissue. A job of a surgeon is just to create a chaos between the tissues and you come out. Let the tape be loose. Don't make it too tight. Whatever is tight is not all right. So make it loose That's it. Create a chaos, the fibrosis will happen and that will take care, and the final results will come say after 5 or 6 months, not immediately. Day one you cannot claim and take a gold medal home after the surgery. So this sacropexy or the pectopexy, it is done laparoscopically or the robotically, both ways it can be done. Time taken is about 1.5 hours. In the laparoscopy, robotic, it depends on to your practice, say about 2.5 hours, because including the docking, de-docking. No great advantages as such, because you are not going into the too deep pelvis, and God has gifted the female pelvis as a broad pelvis, so no great advantage of doing it with that, until unless there is a great amount of bowel adhesions in the post-hysterectomized ladies. Mesh, I told you, best mesh to use is the macroporous soft polypropylene mesh. It is a permanent, good tensile strength, it's strong, and it is biocompatible. Not too much of the reaction happens to this mesh, but I suggest you that the dual mesh is very good. So dual mesh, the chances of erosion are very, very less in this. So what you can do, dual mesh means on the one side there is a dissolving material, polygalactin or something, where you can use that material, that surface of the mesh towards the urethra or the bladder, and the other side, the rough side, to be used onto the anterior vaginal wall. So a fixation gets proper. This material gets out in say 3 months of the time, and the strength comes out in 3 to 6 months. So these are the type of the meshes. So pectopexy, sacropexy, the pectopexy is primarily, I choose it to do it into the obese ladies where there is a lot of fat, leaden, mesocolon, and tough to remove it. Too much of the retraction is needed. So it is good to do it into the obese ladies. Less of the dissection is required, less chances of the nerve injury. If you learn this procedure meticulously, easily, under the guidance of a good surgeon, then yes, very less are the chances of injury to the ureter, which is very common, injury to the vessels, which is again very common. It is something like taking out a diamond from between the time bombs all around, the landmines. So it is a very good surgery, but yes, you should learn it very easily and softly. So that's the birth, laparoscopic birth suspension, where you give the fixation onto the periurethral tissues, you pull it up and fix it to the pectineal ligament. So I suggest that let's do the surgery in both the ways, the birth suspension and the repair of the cystocele and pulling of the anterior vaginal wall, fixing it to the sacrum. If we use both these surgeries, let's not divide it, mix the surgeries, do a hybrid surgery, and the results are much better in this. Aim of the surgery, last slide, is this, that one should learn that what should we be doing to the patient during the surgery. Our job is to increase the strength to the loose areolar tissue which is around the urethra and the bladder neck. We should make the bladder neck intra-abdominal support of the urethra, and we should offer a little bit kink, repair the cystocele so that it should not happen into the later life as well. So don't just do the surgery for SUI or something, also repair the cystocele. So, and vault correction and repositioning is also a part of a SUI surgery. So, thank you for your kind listening. And one should my take-home message that I should say, let's start spending more time with the grannies and the nannies in our OPD time, if we can.
Thank you,
Thank
sir.
you so much. Thanks, Atan. I think that was a wonderful talk.
Thank you.
And yes, there is a lot of evolution now in the meshes. There was a study which was conducted down south. It was a large multicentric trial where they found that it was very difficult to accept these meshes now. But now in the recent few years, we are seeing that yes, they can be used for pelvic organ prolapse, and that was a wonderful presentation. And it's a good idea to be alongside the gynecologist so that we are able to do better things.
Yeah.
Thank you.
Thank you.
Thank you, sir.
The general surgeon, laparoscopic surgeon, or lot of gynae surgery. Is it medical legally safe?
No.
Actually, I don't think it is medico-legally safe, but there are places where gynecologists are not available. Like so there are certain parts of our country where there are many gynacs who do not have access to good surgical necessities, and that places we can award them. But in a place where we have access to good care and good quality care, I think we wouldn't be justified in doing these cases. So I would always want, in my talk I'm going to be speaking a little about this as well. It's always better to work as a team rather than being in our own silos. So finally it's for the larger good of the women's health. So that is how we have to look at it. Because if you look at advanced endometriosis cases and all, we do need to have colorectal surgeons by our side. We are now doing placenta accreta and so many procedures. We require to have a urologist by our side. Likewise, when sometimes, and this is something which we follow in our university hospital, that we tell them that every woman who comes to you beyond the age of 35, you can operate on her, but please get one gynec consultation done, because there are quite a few things which may be, brought out, which can be of good use for that woman. Like they would be investigated for something else, but then 2 years down the lane they would revisit again for a cancer cervix or a cancer ovary, which could have been identified much earlier in those cases. So I think all of us should now look at it with a wider vision and try to work together.
I know that the general surgeons, they can operate onto any of the organ. I have seen the general surgeons doing the endometriotic cases, thinking that yes, I've got a better hand. But while operating onto the endometriosis, they will burn the rest of the ovary and without getting the AMH done pre-operatively. So this is a negligent part from the surgeon, but it's okay. So that's why one should involve both the teams in any kind of surgeries.
Can I put some remarks?
Yes, sir.
Yeah. In this question, practically, if you morally feel that same procedure, if to be done on your family member, and you are competent enough to do, you can go ahead. No court will come in between. But if you are not enough skillful, because there are so many judgments available, when an MBBS doctor has done the surgeries, different varieties of surgery, because he is also a bachelor of surgery.
After bridge course.
And not even bridge course,
no,
MBBS. I am not talking the other party. MBBS doctor is also a bachelor of surgery. So, and people have done it, and the verdict has also come it, but they have to put their presentation properly in the court of law. There are few judgments available for that also. So important thing, if your soul says that what you are doing is the correct thing, go ahead. No problem will be true, sir.
And I think
Thank you, sir.
nowadays there are a lot of quality initiatives which have been taken, like the NABH accreditation and so on. So there are specified privileges which are specified for every person who can operate. So if you can put in your privileges, I think you will be protected under the court of law. That yes, I have the access of doing this surgery. So that shouldn't be a problem.